Welcome to this webinar, which is on understanding self-harm and suicide. This is part 6 of the webinar series, and I'm Dr. Krisha Patel, and I'm the mental health lead for the company. In this session, we're going to be focusing on the crisis plan and safety netting. We'll talk about what makes a good crisis plan, and what we mean by a crisis plan and safety netting advice. In the last session, we talked about why we do risk assessments for suicide. And I mentioned that as a very key point, that risk assessments are not accurate predictors of suicide, and that's not why we do them. We put people into categories of low, moderate, and high risk, and sometimes people don't actually fit into one category, so they can be low to moderate or moderate high risk, or very high risk. The reason we do that is so that we can make sure we have considered fully the risk of self-harm and suicide for that individual, and so that we can make an appropriate management plan for that person. Most people we assess will probably be low risk of self-harm and suicide. So that's this green category here. The first thing to mention when people are at low risk of self-harm and suicide is that there will be a significant proportion of people with self-harm thoughts or who have self-harmed who do not present to professionals. And they will instead rely on self-help and informal support from friends, family, and emotional support lines like Samaritans or Mind. But of course, some people will need a bit more support, and they might access their GP, or they may be appropriate for a service like IAPT, which stands for Improving Access to Psychological Therapies. And what IAPT do is they provide low-level counselling to people, so perhaps 6 to 12 sessions of cognitive behavioural therapy or other types of therapy that people can access either via their GP, so be referred by a professional, or to improve access to the service, they can actually self-refer online. And the service can be provided online. There's lots of self-help materials that the IAPT service can guide the person towards. And it could be done face-to-face or over the telephone, but overall, this is a pretty much well-established service now that is available in most areas of England, and people can access this and get a service much quicker than in the past when they had to be referred to the community mental health team and be on a waiting list. So the services have improved, and IAPT may be appropriate for people who have low risk of self-harm and suicide, and they are suffering from depression or anxiety. They treat a wide range of conditions. They don't deal with severe mental health problems like severe psychosis or things like severe depression, and they generally need to go to the secondary care mental health services, so that's the community mental health team. But they will deal with many common mental health conditions like depression, anxiety. And some people may need the support from their GP, and that could be through just talking, or it could be because they need some medications like antidepressants. And of course, even though at that time somebody may be considered at low risk of self-harm and suicide, perhaps they have not thought about self-harm and suicide and they have mentioned they wouldn't do it, people can deteriorate. So we need to give some sort of safety netting advice and make sure they have some sort of crisis plan. So we could say to them, if things get worse, can you talk to your friends and family? If things get worse still, can you talk to Samaritans or another phone line that they may find useful? If things get worse, speak to your GP. If things get worse and it's out of hours, call 111, NHS 111 service. If they feel their life is in danger and they're feeling very suicidal, they can access A&E services or call 999. So that's what we mean by safety netting and crisis plan. It's a plan of things to do if things get worse. So I mentioned that some people will be low risk, and moving on to the moderate risk category here. So in addition to the things you would do that are appropriate from the low risk category, if somebody is considered at moderate risk of self-harm and suicide, then it may be appropriate that they need a referral to the community mental health team. Perhaps they're suffering from severe depression. They may need more proactive support from the GP compared to someone at low risk. So perhaps the GP needs to be informed and they need to be calling them more regularly. And then at the top of this pyramid, so most people will be low risk, there will be people who are moderate risk, and there will be a smaller proportion of people who you consider to be at high risk of self-harm and suicide. And these people need more support than people who are low and moderate risk. So that might be through the home treatment team. So HTT stands for the home treatment team, which is part of the secondary care mental health services. And they can be considered as an alternative to hospital admission. So if the person is safe to be at home and willing to engage with the home treatment team, because of course they need to engage with them to be able to be treated at home, there is a specialist team called the home treatment team, sometimes they're called the crisis team, and they are able to intensely monitor patients in the community up to 3 or 4 times a day sometimes, and they can administer medications and monitor somebody's mental state, and they can of course bring someone into hospital if things deteriorate, but their aim is to keep people at home if it's safe to do so and treat them rather than bring them into hospital. And sitting above the home treatment team is the voluntary admissions to hospitals. So of course, some people may not be safe at home. They may be at high risk of suicide, and they may be at such high risk at home that they need that risk contained in a hospital environment. So if they agree to come to hospital voluntarily, that should be supported if that is appropriate for that person. Right at the top of this triangle will be those who are at such high risk of self-harm and suicide that they need to be admitted to a hospital under the Mental Health Act. So by that I mean under a section of the Mental Health Act, so an involuntary admission, and that would be for their own safety. So I mentioned self-help in the previous slide. If you can go onto this website called Rethink Mental Illness and download this document, it gives you the most useful tips, and some of the key points I'll just point out now are: just try to get through today rather than focusing on the future. So if people are talking about self-harm and having plans to end their life, this is a really helpful thing to consider. Just focus on getting through the day and not focusing on the future. Don't make the decision today. Just try to get through the day. Talk about how you're feeling with someone you trust or an emotional support line. Contact a health professional such as your GP or the community mental health team. Try to do activities you enjoy which take your mind off what you are thinking. So that could be anything. It could be meditation, exercise, looking at photos. And if you are in real danger of taking your own life, call the emergency services or go to accident and emergency. So I mentioned already, many people will rely on the support from family and friends and support lines and online chats from Samaritans or self-help. So that's your informal support. And if people feel they need professional support, then of course, calling your GP, asking for an emergency appointment. If it's out of hours, calling NHS 111. They will help you find the support you need, or contacting the mental health crisis team. So everyone will have a local mental health crisis team that generally has a 24-hour crisis line. And these are some of the tips they mention in the document. Try not to think about the future, stay away from drugs and alcohol, be around other people, do things you enjoy, like spending time with a pet. One of the most important things is documenting your safety net advice with a crisis plan if things deteriorate. So talking a little bit more about what we should do when we're thinking about crisis plans and safety net plans and how we should do them. So they are individual, so they're made with the patient. So it's not the doctor or the nurse who makes the crisis plan. It should be done with the patient, or the patient needs to think about it themselves, about what their triggers are, and really reflect on those things to make a good crisis plan. So it's also individualized strategies. It's not about bombarding somebody with every phone number under the sun about mental health services. it should be individual. If somebody is sort of going through a bereavement and feeling very low about that, part of that person's individualized crisis plan may be, if things get worse and you don't feel you can talk to family and friends, you can call a bereavement support line or go ask your GP for bereavement counselling. And we should think about activities to instill hope as well. So it's difficult when people are feeling so low and so suicidal to think about things that are positive, and people need those reminders. So talking to the person and reminding them of what they have that's positive in their life, whether it's their children or their job or their pets, and reminding them of the reasons for living. We should think about individual coping strategies and calming and distracting activities. So things, again, like thinking about what the person enjoys. So is it meditation or exercise or pets? Just going for a walk, for example, doesn't have to be intense exercise. Just getting outside once a day for a walk, avoiding drugs, alcohol, social media. So just about thinking what the triggers are and trying to avoid them. And a really key component of any crisis plan, when we're thinking about self-harm and suicide, is restriction of access to means or to common means of suicide. So we need to have asked the patient if they have thought about suicide and if they have thought about doing anything actively to harm themselves. So have they thought about taking an overdose of medications? And if they have, one essential part of the crisis plan is going to be about removing access to stockpiled medications at home. And that could be asking the patient to keep them locked away in a cupboard where they don't have the key and maybe somebody else has the key for that. Maybe telling the GP that this patient feels suicidal and is it possible to only give 7-day prescriptions at a time instead of 28-day prescriptions? And if somebody's thought about hurting themselves by cutting their wrists or cutting themselves, we need to think about restricting access to knives and sharps. So it's all about making the situation safe. And if somebody has thought about using a firearm to end their life, one essential thing is going to be removing access to that firearm by revoking that license or involving the police if needed. And that will be to remove access if that's their own firearm or not have access to somebody else's firearm. And of course, we provide contact details for social and crisis support. So the day-to-day support, so having a list of phone numbers of family and friends, having a list of appropriate charity phone lines, whether that's Rape Crisis or Samaritans or Mind, having the contact number for the GP or the community mental health team. So it's well worth being aware of some of the main national charities for mental health. So Mind is an absolutely essential, really important service to know about because they provide so much support to many people. And there's loads of patient-friendly documents and things on there explaining a lot of mental health problems to patients and families. And they have really useful phone lines and online chats and things like that. So well worth getting to know Mind, the mental health charity. Samaritans is another big one we all need to know about because they are one of the most commonly used mental health charities. They are there for people with emotional distress. It's not just suicidal thoughts, it's emotional distress. And they're there 24/7, 7 days a week, can be done with online chat as well, but commit this number to memory, 116123. I've told patients to put it in their mobile phone. I've even asked them to commit it to memory as well. It's well worth remembering about Samaritans. And SANE is another charity that provides a lot of support. So it's good to know a few national charities working in England, as well as some of the local services. Those three are sort of general mental health charities. And then, as I mentioned, when we do crisis plans, we need to think about the individual patient. So if they've suffered a sexual assault and they've attended the sexual assault referral centre, which is where I might be seeing them, then the most appropriate support service for them may be through rape crisis or a similar support service. And if someone's experienced bereavement and they're feeling low and suicidal because of that, then Cruise Bereavement Charity may be the most appropriate for that person. Increasingly, we're being asked to do pre-release suicide risk assessments on people who have been arrested for significant crimes like sexual offending, particularly child sexual offences. And the Faculty of Forensic and Legal Medicine have provided a guideline on what we should be doing in terms of these pre-release suicide risk assessments. And really, we should be doing the same thing as we're doing for anyone when it comes to a suicide risk assessment. So making sure we've taken a good history, done a good mental state examination, considered the risk factors and done a risk assessment and made an appropriate management plan. And part of that plan may be to involve this charity called the Lucy Faithfull Foundation, which works to protect children, and is a very unique charity because it is there to try to prevent people from committing sexual offences against adults or children, and it's there to support family as well. So it's well worth knowing about that charity in particular if you work in police custody. So that takes us to the end of this session, which is all about crisis plans and what they are and how we make them. In the next session, we're going to go through some scenarios.